somebody named Frank there.
There he's in. Now he's in. Okay. Great. Well, let's let everyone get settled in virtually. I know looks like there's still a few people connecting to audio. We've got a little bit smaller group, but that's fine. We may get a few that come in a little bit later. I have disabled the waiting room so that anyone joining us a little bit after we start will come right in. Good to see some familiar names and faces. Want to welcome you back to our ongoing Essential Substance Abuse Skills Training webinar series. Got Avis Garcia here with us today, and got a couple more people joining. Let's give them a chance to settle in this virtual world that we find ourselves in. Paul, good to see you. I think you've been on a couple of times, a couple of our series, so good to see you again. Thanks for joining. Okay, well, it looks like Michelle is still trying to get connected to audio, but I see she's logged in twice, so hopefully she's got a plan to join us without any problem. Again, I just want to welcome everyone to another installment of our Essential Substance Abuse Skills Training webinar series. My name is Steve Steiny. I'm manager here at the American Indian Alaska Native Addiction Technology Transfer Center at the University of Iowa. And I have with us our speaker today, Dr. Avis Garcia. And I also have on the line my colleague, Parker. He's going to stay on at least initially to make sure that that I don't break something on the Zoom, and which I've been known to do. I won't horrify you with my Zoom trauma, but Parker will stay on for a little bit to make sure that we get started off on the right foot, and then he may just step off. But Parker, thanks for coming on and being here for some support. Again, I want to welcome everyone. We've got some important information we're going to cover today, and we should have a little time. We're slotted until, I think, to go until 1:30 Central. So if we do have some time, which I think we should have a little time at the end, please feel free to post some questions or comments in the chat or use the hand raise feature, and we'll try and have Avis address some of those questions or comments at the end. So again, just want to welcome everyone to the ESAS series. Today's topic is HIV, STIs, and substance use disorders. Got a couple of introductory slides that I'll go through, and then we'll transition to the main slide deck and go from there. As most of you know by now, this event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. We, as I mentioned earlier, are located at the University of Iowa at the College of Public Health, and I'm broadcasting to you live from the 4th floor at the College of Public Health here on campus. We are part of a national HTC network made up of 10 regional centers, a national Hispanic and Latino center, as well as an HTC network coordinating office at the University of Missouri. This project is funded by SAMHSA. The content is developed by the presenters, and the opinions expressed today do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native HTC. Following today's event, we will reach out to you via email. This email will include links to today's presentation. And Parker, I'm pretty sure we are recording now. Just double check and make sure that we are recording. But we are going to record this event today, and we will send a link that this presentation, the recording of this presentation, will be available on our YouTube archive website, our national or our Native Center for Behavioral Health archive site for later viewing. If you have a colleague or friend that were not able to be with us today, you can direct them to that link. We'll also be offering 1.5 continuing education units. At the time that you receive the follow-up email, you can request the CEUs with our Native Center staff, and we will get that electronic certificate to you that you can utilize towards your credentialing or licensure in your respective state. Lastly, there will be a link to a very short survey. If you have a few minutes to fill this out, we would really appreciate your feedback. I'll also post a link to that survey in the chat box today towards the end of the presentation. If you'd like to just get that out of the way right away without having to mess with it in the email, that's fine too. Any responses that you provide cannot be linked to you directly in any way. It is completely confidential. If you have any questions about that survey, please feel free to reach out to myself or Parker here at the center, and we're happy to talk with you about that. I know we are gathered here virtually today, but we do want to take the time to acknowledge the land, pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll and Mr. Sean Bear. Thank you. Well, without further ado, I want to introduce today's speaker, my colleague and my friend, Dr. Avis Garcia. She is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. She's currently living and practicing in Montana, and holds a professional LPC and an addictions therapist license, and also holds a doctorate in counselor education and supervision. She has worked for, I'm just going to say it, Avis, she has worked for decades in the field and has experience working with a number of different patient population groups, including Native American populations. So we are thrilled to have Avis not only as a consultant, but also as part of our advisory board here at our center. So I'll let her talk a little bit more about herself and what brings her here today. And while she's doing that, I am going to just remind everybody that you are currently muted, but you can certainly use the hand raised feature or the chat box if you have any questions or comments. Avis, the floor is yours. I'm going to, while she's introducing herself formally, I'm going to pull up the slide deck. So thank you.
Good morning or good afternoon, wherever it is you're watching us from. I am from the Wind River Reservation in Wyoming, where I lived most of my life. I currently work as the clinical services director for the Crow tribe. I run their outpatient treatment program here for a year now. I really like working with the people here. As Steve said, I've been in the field for a couple of decades now, and it's kind of like, when I think about how long it's been, I'm like, wow, I can't believe it's been that long I've been doing this work. I originally started out in 2001 on the Wind River Reservation right out of my master's program. I tell people I mainly was interested in working with people with alcohol problems because that was what I grew up in my home environment. And so I wanted to be able to go help people with alcohol problems. But when I got my first job on the reservation running a drug court program, I remember the phone was ringing quite frequently, and it was all about methamphetamines. And I had no idea what methamphetamines were or how to help people that were under the influence. And that led me on a quest to go find out how I could help people. And I was sharing with Steve that I ended up in Rock Springs, Wyoming, working in residential treatment, where a majority of the clients we provided services to were there in treatment in lieu of incarceration. Sadly, I would probably say about 80 to 85% of the residential patients were all methamphetamine at the time. And that was in the early 2000s. Like I said, I was new to the field. And now since then, methamphetamine, I feel like has come back again on our reservation in Wyoming. And it's also, I'm seeing it's prevalent here in Montana with a lot of the tribes, not just ours. But today's topic is something, as I was preparing for this presentation today, I feel like I've been here a year and I've been working on a curriculum. And what that means is I want to have like a set classes that our clients need to take to complete their outpatient program. And so as I was doing this, I thought, I don't do enough of this. And I don't know how many of you do enough of talking about HIV, STIs, and substance use disorders, and, how we are working with the most high-risk populations. So I was glad to go through this material again and refresh myself on the importance of why we need to cover this. Those of you that are preparing to sit for the licensing or certification exams, there will be some questions on there about this. So since we are doing this series, it's real important that we take some time out to cover this topic. And it's like, it's not one of those I'm particularly like over enthusiastic about, but it is required. And like I said, I myself feel like I need to do a better job of addressing this in my workplace as well. So I'm glad you guys are here today. We'll go on ahead and get started with today's presentation. And at the end, we'll have some time to address any questions or comments that you might have. Okay, today we will be covering the basics of HIV prevention. A lot of this is prevention, describe common STIs, sexually transmitted infections, explain the core components of communicable disease prevention, explain factors that impact the risk, and also cover 2 strategies that substance abuse providers can use to prevent HIV, STIs, and viral hepatitis. These are the core competencies under SAMHSA, Competency 106, understanding and describing health and behavior problems related to substance use, transmission, prevention of HIV/AIDS, TB, sexually transmitted diseases, hepatitis C, and other infectious diseases. The other competency is 105, which describes the principles and philosophy of prevention and treatment and recovery. I would also like to add that there is a tip 37 from SAMHSA that is real specific to substance abuse and the topic we're covering for those of you that are interested in more information. It's free if you get onto the SAMHSA website. This is why we're covering this. We can go to the next slide. Here are some statistics. They're a little outdated. I was actually getting online earlier yesterday to see what the up-to-date numbers are, and it hasn't changed much. Um, the number of people living with HIV in the United States is higher than ever before. About 1.2 million people in the United States are living with HIV at the end of 2012. Of the people that have it, about 12.8% do not even know that they are infected. Some people don't have any symptoms right away, so they don't know that they have it. About 50,000 new diagnoses are made each year. And when I was getting to the specifics of the Native American population, the Native American population makes up approximately 1% of all of these cases. Consistent increases may be due to higher proportion of people living with HIV infection and knowing their status, surviving longer with antiretroviral treatment. So I remember when AIDS first came out and everybody was worried and scared, and it was like it was a death sentence. And there was a young Native lady who had come to our reservation, to educate our community and increase our awareness of the problem. And so I was really, interested in that. She had AIDS and she was coming to share her story with us. And it was interesting to know, like, a lot of people thought if you just were around the person that you could catch AIDS, and that's not how it's transmitted. People are surviving longer. As we progress, we'll talk a little bit more about the treatments that are being used today and how effective they are. Becoming infected with HIV, then okay, consistent increases becoming infected with HIV than the number of people who die each year with HIV or AIDS. So people that are infected, there's more of them actually than those that die. We can go to the next slide. This is some statistics by region. And if you look down south is a much higher percentage. It's over half of this pie chart here. The West is looking like about a third of this side, the Midwest, and then the Northeast. But the South is more down in the more, I want to say more warmer areas of the country. And I was also doing some reading on HIV and the statistics, and it talks about the risk factors are the highest cases by race is the Black population, and also the lower socioeconomic population. So that was kind of breaks up these statistics right here. So I thought that was kind of interesting. Of course, the natives were at the very bottom, but it doesn't mean we're still not affected by it, because I've known people that have died from AIDS in my own tribal community. Routes of transmission. The most common is having sex without a barrier, not using any protection, no condoms. And the other most common is sharing previously used needles and works. So it's not just with here with a lot of the opioid use, we've been talking about having the clean needle exchange programs, which is also helps to prevent those kinds of problems. And so that drug users, people we work with, are more likely to have a higher risk of exposure to AIDS and the HIV. Almost eliminated in the US is the occupational exposure. Those are people that have jobs where they may be exposed to blood, nurses, people in labs, even people that work in residential treatment. I used to have to search people's bags and do room searches. And, as I was reading this stuff, I was like, man, I don't think I was even really being really careful of that something sharp could be in their bags when they were coming in, or stuff they might have had in their rooms. So there's that occupational exposure. A lot of people in the medical fields contaminated blood products by transfusion, and I know they do a lot of upfront screening before they take blood donations. And then there's also the parent to child, prenatal and breastfeeding. But now there is medications that can prevent children from getting AIDS at all, which is very important. And we can go on to the next slide. The sequence of events in HIV infection. The acute infection is from days to weeks of viral transmission. Some of the symptoms that are noticeable could be a sore throat, the rash, the sweating, fever, and fatigue. So real similar to flu. And massive viremia. Asymptomatic infection can be 2 to 12 plus years. This is what I mean. Some people have it and don't know because a lot of people just don't go get tested. Persistent massive daily production of HIV, gradual depletion of the CD4 T cell population. And so the CD4 T cells are those that help our bodies to fight infection, and that is what gets depleted. And following that is the AIDS diagnosis. So a lot of people get HIV, don't all get full-blown AIDS. So there's a CD4 T cell count drops below 200, and also opportunistic infections. We can go to the next slide. This here is called the treatment cascade. And if you look at the numbers on the left, this is a number of individuals that are diagnosed with HIV. You see there's over 1 million people that are infected. And the next bar to the right are those that are diagnosed. The next bar shows how many actually get linked to HIV care. So not everybody gets linked to care. Some are retained in care. So if you look at that top bar, about half of the people are ones that actually get into care and stay into care. So a lot of that, this is our job, is to help these people connect to services and using our case managers and resources to get these people motivated to take care of themselves. And then it drops. They need antiretroviral therapy, just a little bit under the halfway those retain. And then the next one drops to antiretroviral therapy. So that's the ART therapy. And is there, somebody's got some, okay. Somebody had their.
Yeah, I've got it.
Okay.
Yeah.
And then there's some that are adherent and undetectable. Once they are on this medication for a while, this ART therapy, their symptoms and the viral count in their bloodstream can drop to almost normal, to the point to where it is almost undetectable. So it's like I said, people are living healthy, longer lives now with proper treatment and care. You can switch to the next slide. And treatment as prevention. So a lot of our work here is doing prevention because we do work with the most high-risk population. Research shows that the value of the antiretroviral therapy reduces the viral load and decreases the likelihood of transmitting the virus. A person not living with the virus can take HIV medicines to protect themselves, almost like vaccine-like, from the infection. So I even have heard that sex workers actually take these. We can go on to the next slide. Linkage to care. Structured programs that move people from diagnosis into stable care. This is our job, where we come in as helping these people work through their barriers, their fears, and their misconceptions. You know, a lot of people will go through anxiety, they can go through depression, and it's very important that you know what services are available in your communities, even places that they can get tested. I saw somebody logged in here from Buffalo, New York. I'm like, wow, this person's like in one of the most major cities in the country. And right now I'm in this very rural area where we're very limited on sources that I can refer people to, but you know, we have Indian Health Services here. Helping them work through administrative barriers, you know, getting into programs if there are any available, and navigating environmental barriers. One of the programs that I worked at before I moved here, we had some special funding for AIDS patients. So if any person that was diagnosed with AIDS in the county, actually where I was living and working, qualified for free treatment services at our program, and that was covered under a program. Linkage to care also means evaluating the available care options, working with insurance and affordability options. A lot of the people I work with here are very low income, so most don't have insurance, and our job is to help them apply for Medicaid that helps them qualify for some other health insurance where I'm at currently. Linkage to care programs are not required for all people, but should be required for all programs. So it just comes down to knowing all of your resources and where you can send people to get the medical attention that they need and just to get tested. Now we'll talk about the sexually transmitted infections. I don't know why there's a red mark in the screen.
I just noticed that too. It's not on my
Okay.
presenters. I don't know where that's come from. So I don't know if anyone would know. We do have a hand raised. Fawn, would you like to comment?
I don't know about the red mark, but I was wondering if there's a copy of these slides available to us.
Yes,
Yep.
we will.
Yep.
We
This
will
is-
reach out in the follow-up.
And
Every-
I've been on other presentations where people have hacked them and then they start by doing those little stuff. So just beware, okay?
Gotcha.
Okay, thank you.
Yeah, every webinar that you attend through us, you always receive a copy of the slides. Yeah, we don't know where the red mark came from. It's just there. Okay, sexually transmitted infections. We have the bacterial infections, which is the gonorrhea, chlamydia, and syphilis. These are curable with antibiotics. We also have the parasitic, which are the pubic lice, also known as crabs, and scabies, also curable with antiparasitics. And then to the far right here, we have the viral, the HPV, the HIV, the herpes simplex virus, and hepatitis A, B, and C. These are treatable, but not necessarily curable, but they are also preventable. So it's like I said, we're all about prevention in our treatment programs. Hepatitis C, newly infected are either asymptomatic or have a mild clinical illness. HCV RNA can be detected in blood within 1 to 3 weeks after exposure. The average time from exposure to antibody to HCV seroconversion is 8 to 9 weeks. Again, when we first started detecting this problem and treating people, it was a very serious condition. Again, with all thanks to medical technology, there's some medications out there that can be really effective for helping people with this. Real common in drug users that are IV users. Chronic HCV infection develops in 70 to 85% of HCV infected persons. 60 to 70% of chronically infected persons develop evidence of active liver disease. So this really hits the liver pretty hard. Most infected persons remain unaware of their infection because they are not clinically ill. I mean, they'll feel no symptoms. So it's really important when you see your clients, when you're doing that assessment early into their program, to ask them when is the last time they saw a doctor, and really suggesting and encouraging them to go get themselves a physical and get some tests done for themselves.
Just an FYI, I solved the red mark.
Ah,
I called Parker and I must have hit the annotate button. So I don't think that our webinar has been compromised. I think we're fine. So sorry.
okay.
Sorry for that interruption.
It is gone.
Thanks, Gene, for at least giving me a heads up. I called our IT guy and he knew what was going on. So thank you. Sorry for the interruption.
No problem. Thank you. Thank you, Parker, for taking care of our little red mark. These are the new HCV regimens. And if you see, they start at 2013 and go all the way up to 2015. These are the brand names, all used to treat hepatitis C. These are the generic names, and then these are the genotypes. So it gets up to 100%. Some are in the low to mid 90s. So these are the new treatment regimens that are given to people with Hep C. And working in residential treatment and outpatient treatment, I've really encountered a lot of clients. Like I said, we work with the most high-risk population. So I was somewhat relieved to learn that there's more treatment available so that they don't feel like, it's a death sentence, or they're gonna have a lot of health problems. Like I said, a lot of them, just like with the AIDS treatments, are living healthy, long lives thanks to medications that can treat that. Okay, hepatitis C, HCV co-infection. Routine testing for HCV or for any HIV positive person is important because those two in combination can be really detrimental. Early diagnosis, evaluation, and treatment of HCV should be considered for HIV patients because the HCV increases their hepatotoxicity. That's a word. That's their liver damage on the antiretroviral therapy. May increase HIV progression, morbidity, and mortality. So if they have this in combination, the co-infection, it's very serious. HIV increases hepatitis C viremia. So that increases the hep C in the bloodstream, the viral impact. Hepatitis prevention opportunities in existing programs. All programs, clients need to be educated. We need to do risk screening and providing counseling services. So there's hepatitis A and B vaccinations, hepatitis C screening, counseling, referral, and behavior change, and interventions. So these are all things that we could refer our clients for. And like I said, it's our job to educate them of these problems as well. I'd seen somebody comment in the chat box to access the slides. They will be emailed to you shortly after this presentation, along with a short survey. So if you must have missed that at the beginning. So after every presentation, we do send the slides, and it's just a quick little survey that we send out. Okay, on to prevention. There are different levels of intervention. Intervention refers to the mechanisms and strategies that are used to operationalize or achieve a level of prevention. So what would you do? Here's a question. What would you do to promote the idea of using condoms? You can put your answers in the chat box. I have been doing this work long enough that we have bowls throughout our building that we keep replenished, and Indian Health Services does a really good job of keeping us stocked up. So it's important to just have them available. Interventions are the opportunity to directly connect with the individuals, communities, or systems that are creating or perpetuating risk in order to eliminate or mediate the risk. Interventions are always trying to change something. So that's an intervention. And providing condoms is one intervention. What is the most effective in structural level intervention? This is policies and systems. Like I said, that tip 37 from SAMHSA goes into greater detail with all of this information here. So those are the policies that your program uses and operates by. Some people actually will fall under certain policies and systems. Community level intervention. So these are community level norms. And I like to say wherever we work or wherever I'm at, my job is to serve that community and the people that live there. So being focused on prevention, the most high risk population is our people beginning at age 13 up to the age of 54, and that big age range are the most people that get infected. So it's good to start out with these preventions early. And I've been asked recently to come do a presentation for youth that work for the tribe. And I was like, this is something I need to add to what we're going to be sharing with the youth that are working here this summer. A group level intervention. So this is individual behaviors for group settings. So those of you that are running group treatment programs, this might be a good group session to have, which, like I said, I'm going to incorporate this into our curriculum and make it a required one. I do know some states that do certify people, require them to get so many hours specific in HIV information. So I think, I'm trying to think, our state doesn't, but I did read that there are some states that do require it. Individual level intervention. So this is individual behaviors. So, when you're doing your intakes and screenings with people for the very first time, that's your opportunity to use some micro counseling skills and, just ask, when's the last time you went to see a doctor and had yourself thoroughly checked out. And adolescent evaluation that we use goes into greater detail. I was pretty surprised at the questions that are asked, which I think does a better job than the one for the adults. But when we're talking about prevention, if we can get the people younger, that I feel that that's the best thing we can do, is reaching our people at younger ages.
Avis, that Michelle had her hand raised. I just was going to see if she wanted to ask a question directly.
Okay.
Michelle?
Hi, good afternoon, or yat ehpene, everybody. This is Michelle Singer. I'm a citizen of the Navajo Nation. I use she, her pronouns, and I'm coming to you from Portland, Oregon.
Okay.
With the Northwest Portland Area Indian Health Board. Avis, I just love that you're presenting on this topic, and University of Iowa is picking it up.
Thank you.
I just wanted to let you know, I love everything about this. The Northwest Portland Area Indian Health Board is coordinating a national Native network of regional and national partners in addressing the HIV/AIDS, substance use disorder, STI syndemic. I put a handout in the chat feed, but we are big on prevention, education, health promotion, especially culturally relevant education. And we do have social marketing materials all around all these topics. And I know University of Iowa has tapped us to put some information on the University of Iowa ATTC website. So I just want to let folks know, if you're looking for, discussions or how to talk about STI, HIV prevention, SUDs, we have curricula, standalone lessons. Oh my gosh, information for around condoms, the importance of it. That's all socially and culturally identifiable and relatable. And then we do have partners out of Alaska and the Southern Plains Tribal Health Board that have self-testing HIV, AIDS, STI kits that people can get for free and order by just simply texting. And so there's a lot of innovative work that's being done. And I just thank you for bringing this to the stage. And I put a handout in the chat feed. And I just want to give a shout out to our funder with Indian Health Service, who is an absolute rock star. If he's still on, Rick Haverkate. He is our fearless leader, and there is a national Indigenous framework, strategic plan addressing these issues. And if Rick is willing to say a few words, but check out our handout. I want the kit. I know mine out of Alaska, Southern Plains Tribal Health Board, and of course, our board. So thanks so much. I'm just so excited.
Oh, thank you so much for sharing all those wonderful resources. I'm excited to see a lot of that myself. That's great. I'm glad to hear somebody's just really stepping up and getting real involved in this important
And the
issue.
fun stuff is
Thank
the
you.
youth are in it. They want to,
Awesome.
I mean, we just had a youth workshop and youth were beating condoms, and using them as necklaces and creating snag bags that have this information in there, and texting sex to 94449 for sex ed for the summer. I mean, there's all kinds of cool ways to do all this kind of stuff. And then Talking is Power is a text messaging service for parents about how to talk to their youth about sensitive subjects and becoming an askable adult, about condom use, healthy relationships, about testing, and they themselves leading by example. So I did put that handout in the chat feed. I'm always happy to help support you all at University of Iowa and what you're doing, but we are with it. We are with you. And just consider us an extension of your HIV, AIDS, STI, SUD family.
Thank you. I really appreciate it. It looks awesome. I appreciate this
Thank you so
resource.
much, Michelle and Rick.
This is exciting. I'm glad to hear you have all these youth who are actively involved in taking a lot of pride in being a part of getting the message out.
I'm still stuck on the condom necklace, Michelle. I got a nice chuckle out of that. I love that kind of stuff.
I'll put a picture in the chat feed. You'll love it.
Okay.
And they actually made earrings. They did a beaded workshop called Sex is Sacred. And
oh my God.
both young people, he, she, y'all, and they made earrings, necklaces. I mean, they were proud to be able to take away the stigma around talking about condoms. And I think sometimes even adults are more scared to talk about it than youth are.
Well, for me, as a cultural perspective, it was taboo topic, and when I grew up, and it's through going to college and having to do the work that I do has been a real game changer for me. And I've even, I've been a school counselor too, and have had parents not be happy with some of the information. I was like, but I feel it's very important. It's just educational. Some people see it as you're promoting it and not preventing. So I think it's great that you're getting that. I made all kinds of notes here, so I'll be visiting your website to share this information with my adolescent counselor that I have on board. Great stuff. Can go to the next slide.
Did I mess up my slides? Are you guys
No,
still, you're
we're,
still
we're,
seeing them?
yeah.
Okay, okay.
Okay, so it talks about which one do you choose? Like, what's the best way that you want to help your community? First is to examine your community and the risk populations. What is appropriate for them and the issue? So asking the community what it is they want. Looking to the science, what is effective and what is the most affordable. A cost-benefit analysis can help you to determine what may be best. An example on the right here is an individual level interventions are expensive but are effective. Group level interventions reach more and are marginally effective, and community level interventions reach more people, take longer to affect change, but can produce opportunities for lasting change. And then the last is the structural level interventions, which produce lasting change and can address the root causes and social determinants, but are complex and often not supported with federal dollars. So it's actually, you could touch on all of that. One does not necessarily lead to the other. So a high-risk incident isn't always equivalent to exposure. Exposure doesn't always lead to transmission. Transmission doesn't always lead to the infection. And infection doesn't always need to be the spread. Like I said, with some of these medications that they're giving now, it's amazing that some people live normal, healthy lives because the virus is like almost undetectable now with the treatments that they can receive. Substance use treatment providers can conduct HIV, HCV, and STI prevention through individual and community practice. Why substance use service providers? We have experience with behavior change professionally. We are engaged with high-risk clients every day. Instills a sense of accomplishment, self-improvement, and value of health seeking. So when we're talking about working from a strengths-based approach, you want to be able to, recognize that somebody's taking the right steps. I mean, just coming into their first group, that's action. When we're looking at that change, stages of change, they're actually showing up. That's they're taking action. So, being there to support them and build them up for, trying to take care of themselves. Reduces the number of IDU occurrences and HIV risk behaviors under the influence. So a lot of these people that are engaging in substance use, drug and alcohol, they're at a much higher risk than those that don't use any substances at all to engage in the behaviors that could transmit the virus. That includes the people that are using opioids nowadays and taking them intravenously, and any substance that they use by IV because they're sharing drugs. And so, like I said, the sharing of their needles, whatever they use to take the drugs is a real common, the second most common transmission of these diseases. We can change to the next slide.
Avis, Scott had his hand up. I just was going to see if he had a question for the group.
Okay.
Hello, can you hear me?
Yes.
Thank you. My question is, if somebody had AIDS, their T cell count dropped below 200, and with treatment, their T cell goes back above, do they retain the AIDS diagnosis, or are they now considered HIV positive?
That's a good question.
That's a great question. And I thought that Rick had addressed that in the chat. Rick, do you want to jump in there or?
Yeah, thanks, Steve. Thanks, Avis. This is Rick Haverkey from Indian Health Service. I really appreciate this amazing webinar you folks are organizing and showing. So hello, everyone. Good question, Scott. And I did put that in the chat, so you might scroll back and look. But basically, is really important to know that there's no cure for AIDS. However, if a person living with AIDS gets on those medicines that Avis has been talking about, those antiretroviral therapy, stays in care, gets to an undetectable viral load, they're virtually incapable of transmitting the virus. They will live long, healthy, productive, normal lifespan. And we can refer to them as a person living with HIV. I can't say that the science will tell you they don't have AIDS, but AIDS diagnosis usually means a measurement of your CD4 as well as your viral load. So we don't have to say that's a person with AIDS. We can say it's a person living with HIV.
Thank you,
Okay.
Rick. Could I
Okay.
ask one more question?
Mhm.
I'm sorry.
No.
I read somewhere recently that statistics show that African Americans right now are at a higher risk of infection. I'm not sure if that's still true, and if so, like why that might be.
I think when I was talking earlier about the geographic breakdown, when we showed the pie chart, like I said, I have read that because that is in the southern part of the country, there is a higher population of Black people, which also includes the lower socioeconomic and people that are using substances. Right.
So thank you.
Mhm. Yeah, when you look at the CDC website on the current AIDS diagnosis and HIV, you'll see when they break it out by races, the Black has got the highest bar of all the races there. And then it just drops down where the Native Americans are it says 1%, but I'm like, we make up 2% of the population. So that's still a big significant number for Native people. But good questions. Why substance use service providers? People living with HIV require HIV treatment and disease monitoring, but may be hesitant to access medical care systems, require consistent medical monitoring, and may not have insurance or know how to access care. Right where I'm at, like I said, we're right close to an Indian Health Services. So I've been working from the psychology department to try to integrate services, and this just makes me realize that we are in a perfect position to reach these people and to encourage them to go get tested. And I was actually having a bright idea while I was preparing for this presentation of my curriculum and some sort of incentives. And I know on my reservation, gosh, I want to say a decade ago, we actually had an HIV testing federal grant from SAMHSA on our reservation. And they did do a lot of testing and gave incentives for that. And a lot of the work I've been doing in substance abuse does show that, you know, incentivizing some of the treatment has proven to be effective with clients. So that would be a good way, I think, to help encourage our clients, you know, to get themselves tested and make sure their health is in good condition, or, you know, how they could take better care of themselves. So I think having everyone go get a physical that comes to substance abuse treatment should be highly encouraged, and including the testing. And service providers can be the bridge to HIV care. So oftentimes I see clients make connections with their counselors in the program. And now we try to make our staff more available to our clients by having, you know, cell phones that they can contact us whenever they need to. So they do need support. And I feel like we're on the front lines there, and that's what we're there for, is to give them the support that they need and also help them get the right care that they need.
Fawn has a question too. I see her hand is raised. Fawn?
Okay.
Yes, hello. I was wondering, are there any resources that are specific to tribal communities for people who may be infected with the HIV virus?
You know, you ask a really good question. I can still consider myself new to the community that I am in. And I keep speaking of Indian Health Services because that's all I know where I'm at. I haven't, we are rural, but we're close to Billings, Montana. And I would only assume that if I needed to find more services, that's probably where I would find them. Like I said, it's important for us to find our resources within wherever our work settings are. And as far as real specific to natives, I don't know if there's someone out there that might have information that I don't have. Michelle?
Yeah, I didn't know if there were any like federal initiatives or something. I think that would be the only thing that would apply, you know, to us specifically as a group.
Okay, yeah, that, like I said, I want to say a decade ago on our reservation, the federal resource was federal grants, and that was for HIV/AIDS prevention on our reservation. And that was, God, that was quite some time ago. And I don't know of any program like that now.
Okay, thank you.
Fawn, can I ask too, where are you located? What?
I am in Wisconsin.
Okay, okay. Yeah, there may be some TTC resources in, I think it's Region 5.
Okay.
If you email me, I can try and connect you with Region 5. They also may have some resources specific to your TTC region through their prevention department.
Okay.
This is
Okay,
Michelle Fawn.
thank
If
you.
you wouldn't mind emailing me, I can put you in touch with a woman named Rachel Chambers, who is in Wisconsin. She works for the Johns Hopkins Center for American Indian Health, and they do the I Want the Kit that helps on HIV self-testing, and could definitely work with you. It'd be a great connection. So if you email me, happy to make some connections. You know, of course, we have many websites, but our page that we were showing earlier, if you scroll down to the AIDS, HIV, as well as information for providers, allies, which means families, etc. So happy to make some connections.
Thank you.
Good questions. I'm glad we had Michelle on here today. She's got some excellent resources.
And Rick too. Rick's
Oh,
been great.
yeah. Yes.
There's a great comment he put in.
Rick, do you want to put your IHS HIV AIDS page up, link, since you might have it handy? That's a great resource page as well too.
Sure, I'll do that. Thanks, Michelle.
Okay. Prevention as a core function. Of course, prevention is to interrupt the spread and perseverance of a condition, any condition, substance abuse, sexually transmitted infections, and HIV. These can all be prevented. Prevention is a core function of public health and behavioral health practitioners. The current prevention foci, we're looking at sort of a balance between the behavioral and the biomedical. The behavioral involves examining the individual and communal psychosocial components of their behavior and implementing strategies to alter them. These can be delivered individually, in a group setting, and in the community. So those are all 3 levels of prevention that you can work with. The biomedical involves the use of medical science to intervene in the biological and pathological operations of the virus or bacteria. So that would include treatment, the PrEP and the PEP and the microbiocides and circumcision. So this is all from the medical profession. I don't know if Rick wants to speak to that a little bit.
Can you ask that again, Avis? I'm sorry, I was reading that comment in the chat and I missed your request.
Oh, sorry. I was looking at this biomedical slide involving the use of science to intervene in the pathological and biological operations of the virus or bacteria.
Yeah, so that's incredibly exciting. I'll just take a minute to say, like, this is the stuff we dreamed of 40 years ago. We thought would never happen. So while I'm reluctant to call things miracles, this is really about as close as we can get when we think of these biomedical interventions like PrEP and antiretroviral therapy, treatment as prevention, undetectable equals untransmittable. I mean, who would have dreamed we could have gotten here? However, I think it's really important that we keep in mind the good old-fashioned health education, the stress to wear condoms, the stress to make wise decisions, being careful of putting ourselves in situations where our inhibitions are lowered and our just good decision-making skills go away, including substance use. Those are really important. But boy, this biomedical stuff really is what's going to push us towards that ability to eliminate new diagnoses of HIV.
Thank you. So a combination of both behavioral and biomedical expedited partner therapy, testing, PrEP, and medication adherence are both a good combination for working with people. Family roles as a primary vehicle for socialization. Families can, in the short term, create a social support network, foster access to healthcare, model positive communication and behaviors, avoid hypocrisy, and provide opportunities for dialogue. In the long term, value open communication about personal issues, value norms and diversity, and de-vilify sex and combat gender norms. So the family is always a huge support with whatever issue they're facing, as well as all substance abuse. The communities have a responsibility to establish resources and access to resources for HIV and substance use, create social policies that emphasize health, wellness, equal access, and disallows discrimination. Communities have opportunities to shape those norms around sex, around drug use, looking at risk reduction, harm reduction, and gender. Encourage sexual and substance use education in the schools, and create policies around syringe service programs and safer injection facilities. So our program that I'm working with has been covering all of those on the bottom there. We get calls a lot lately, and we do the like the Narcan trainings and talking to the kids. We go into the schools and talk to them about mostly drugs. And now I'm seeing, we need to throw sex in our presentations when we go into the schools here. You can go to the next slide, Steve. The system's roles are mechanisms through which formal services are delivered. So we need to understand the community's needs, align those services to meet the community's needs in the community, and make it fit the community cultural. A lot of evidence-based interventions need to be altered somewhat to meet cultural needs in specific areas, work to alter potentially harmful community norms, ensure access to those services, design and provide services through a health equity lens, provide the list of preventive services, and modify systems to accept a variety of insurance carriers. So the community viral load, we want to look at the community as if it were a person. Just like a person has a viral load, a community can have the same. Look at the sheer prevalence of HIV. So what are the rates in your community, in your area? And look at the community's viral load. What can be done to lower a community's overall viral load? Looking at prevention and looking at treatment.
Hey, Avis, can I make a quick comment right there?
Yes.
I think that's such an important slide. Thanks for sharing that. I think that takes a lot of the stigma away. When we first started to unroll PrEP, I lived in Washington, D.C., and they were getting it into the African-American community of people identifying as women. And someone said, well, that just allows you to be promiscuous. And she said, it's not a question of promiscuity, it's a question of prevalence. If HIV is in your community, like your slide shows, then you are at more risk. So we can't point fingers at people who take PrEP and blame them for being promiscuous. It's about reducing that community viral load. So thank you.
Okay. Good point. We go to the next slide. What can a substance use disorder treatment provider do from a clinical and individual? Include indicators for HIV, STI, and HCV risk in all assessments. So when you're doing your drug and alcohol assessments, you might want to run some screens for this in your intake paperwork. Include actionable items on HIV, STI, and or other HCV in all treatment service plans. Include families and partners in counseling sessions to discuss risk and provide education. Key into what environmental and social factors contribute to not just drug use, but also sexual health risk. Become involved with Ryan White case management care teams. What can a substance use disorder treatment provider do? On a clinical and individual level, conduct the HIV, STI, and viral hepatitis screening and vaccinations. Provide referrals and assist with medical linkage to care for those living with HIV or HCV. Discuss medication adherence as part of clinical practice. Provide basic HIV and STI education for your clients. And also, since this is substance use disorder treatment, we really want to be encouraging abstinence from all substances, because using those substances is not going to make the treatments be as effective, and also increases that risk. So we want to encourage that at the same time. What can a substance use disorder treatment provider do? Environmentally, you can create an environment where it is okay to discuss sexual behaviors and identities. I think Michelle talking about the beaded necklaces and was something a bit intriguing for me. Serve as a conduit for information for individuals and families. So if you have information, I always tell people, each of you goes out into the community and you can go share this with another person. So you can spread this information to other people. Like when you go home from group today, you can go tell, your family or your friends you were with, what you learned today. Making condoms available. Like I said, I've been in treatment so long, we always have containers or something available filled with condoms, and we keep them stocked pretty regularly. Programming that makes syringes more accessible to high-risk users. Integration.
Avis, this is Michelle. Could I just share
Yes.
a little story here really quickly? As I mentioned in
Yes,
Portland last week, we
yes.
just had and I think my internet might be unstable, but just wanted to let you know that last week here in Portland, we hosted an all-week summer youth conference for that was suicide prevention oriented, and we had a group of students from our local youth treatment organization. And we had different tracks. We had Painting is Big, where youth painted a mural here in Portland on Portland State's campus called, and it stated, they chose the phrase "culture is resistance." We did the Sex is Sacred, and we also did a Movement is Medicine, and also a Beats Lyrics, where students wrote their own lyrics, music, etc. But what was interesting about this is we saw right outside our Portland State Native Center, there was two things going on. One was a houseless community. And secondly, across the street, sadly, there was a couple that was shooting up. And here you had students that were in treatment. And they saw this and had nothing but compassion because they could see from their lens about how these folks were spiritually not well, not to mention just not well, period, and a lot of compassion. The thing that struck me is that the youth they worked with a local community group called Portland Street Medicine, and they learned two things. They prepared a good medicine street care kit for some of the houseless people, and had a little bit of training about how to show compassion and be of service and outside of themselves for those in that situation. And secondly, they also had a Narcan training materials that were there. And it was really interesting because it was a strength-based approach. It was holistic, but also too, it really embodied, you know, from a recovery sense, you know, the medicine wheel concept from the youth lens. And I just really thought that was pretty powerful as we're talking about this, because this is all fresh in my mind. And of course, looking to each other about how to reach out for help and having resources that are readily available for them, as well as their educators and chaperones. So I just think that what you're saying here with advocates, education, collaboration, but just also coupling substance use disorder along with mental health and the issues around needle exchange are so important. So anyway, I just had to share that because it was on my heart. It's still fresh in my mind, and pretty powerful stuff too. And happy to always share how we did some of these activities, because everybody learned and came away from that experience, I think, a little bit stronger mentally, physically, socially, and culturally.
I really appreciate you sharing that. I've made a bunch of notes in the margins of my notes that I have here. And like I said, I've actually been asked if we would come and do, you know, a couple of hours with the youth workers. And you just gave me like tons of ideas of, these are all important topics, suicide especially. And the fact that you had so many youth that were, sounds like they were just really excited and really into the whole conference by participating in everything that you shared, you guys covered. So I'll definitely be checking your website out, and I appreciate you sharing all of that with us today. Thank you. I think we're on our last slide here. This is talking about being solution focused. Prevention services when working with active drug users utilizes a positive service delivery model. So that is using the strengths-based approach, like Michelle was talking about. Always with substance abuse people, you always want to work from a strength-based approach, and with natives, collaborating with the client and writing down their strengths as a way to empower those inherent resources. Part of our assessment, they call it a SNAP, and the very first S is, you know, what are your strengths? And it sometimes it makes me feel really sad when I get a lot of these people that can't even give me one, you know. So I try to think of something that they can find that they do have, see that they actually have strengths. Addresses overlapping, intersecting, and co-occurring disorders and diagnosis, conveys authentic interest and mindfulness, and acknowledges and provides support for positive steps already made. For example, scheduling their appointment, scheduling to go get tested, the client, you know, whatever they identified their needs that they have. It is our job to support them and guide them and be there for them. That's why we're in this profession, is to help. I mean, you gotta love helping people to do this work, because it's not an easy job. We are also advocates from a frontline perspective and monitoring those emerging trends. So like I said, today I was able to go back to look at some of the data and see where we are. And like I said, sadly, it hasn't changed much despite, you know, all of the drugs, the treatments that are out there to help people. So it's it's a trend that doesn't seem to be changing significantly, other than the death rates are decreasing because of the advanced medical treatments that are available. And that, I believe, is our last slide here. Thank you guys all for taking time out of your busy schedules to be here. I hope you learned something valuable that you can take to your workplace.
Well, I was trying to I was trying to email Michelle, so I'm sorry that my email screen came
Yeah.
up on the share screen. See, I tell you, I can break Zoom if I try. I'm pretty good at that. But again, I echo what Avis has said. Thank you so much, Michelle and Rick for adding some comments and fielding some of those questions. So we really appreciate that, and want to, of course, thank Avis for her presentation today, and all of you for joining us and sticking with us throughout this webinar. We will reach out to you post event via email. If you didn't have a chance to fill out the short survey in the chat, you'll have another opportunity to do that when we reach out after today's event. We will offer 1.5 CEUs. You can request that at the time of your follow-up email, and we'll be sure to get that certificate to you. Avis, or any audience members, any closing thoughts or questions before we still have about 10 minutes, but I just wanted to check in and see if there was any other questions or comments.
I just wanted to remind everyone that if you look up that tip 37, it is full of a lot of really helpful and interesting information on the topic that we presented today. And it's free on the SAMHSA website.
Yes, and I know TAP 21 also has some specific resources connected to addiction counseling competencies pertaining to the topics that we've discussed today. So there's quite a bit of resources available, and I think you can get a lot of the publications now in PDF form.
Yeah, they all are.
Yeah, I ordered a whole bunch of paper copies, and but it's a lot easier to get them in the PDF.
Yes, it takes
Save a
no
few
shelf,
trees.
no shelf space
I
needed.
know. So if there are no other questions, I want to just really thank everyone for your attendance and participation today. And we're going to broadcast next month. I think we're talking about group counseling next month for our August broadcast. So join us first Wednesday of the month, and we'll see you then. And until then, please stay safe, stay healthy, and most importantly, stay connected. And we'll see you again soon. Thank you, everybody. Bye-bye.
Thank you, Avis. Thank you, Steve. You guys did an awesome job.
Oh, thank you, Michelle. It was great having you on. And I'm glad to know that you've connected with Teresa and Eleanor and a few others at our center already. I thought your name looked familiar, but I was just seeing if you were in my contacts. You probably are already. So
Yeah.
perhaps our paths will cross again. And but I may reach out to you just to see if you'd like to collaborate at some point in the future.
Please do. We have a community of practice that's held every month. We have recorded sessions the second Wednesday of every month. And we did a just 2 months ago standing up to HIV/AIDS stigma, and it was a very powerful. It was recorded, but also too, we have a monthly e-newsletter that comes out on healthynativyouth.org. You just go to the bottom and sign up. But no, we are all talking the same language. I'm just glad we've got different venues to do it. So always happy to contribute, and just, we're happy to be of service to the University of Iowa in this way. So glad we're on your website.
I know, vice versa. I'm glad you have some connections here already. So take care, everybody, and we'll see you again soon. Bye-bye.